Good morning, good afternoon, and good evening. My name is Tom Nguyen. I'm a cardiothoracic surgeon at the University of Texas Memorial Hermann. Thank you for attending the CTSNet live stream event, Cardiac Surgery, Restart, and Beyond. As of today, there have been more than 7.5 million confirmed COVID cases worldwide, with millions more undetected, undoubtedly undetected. We're still in a pandemic, and in the United States, there are concerns of a second surge. We're also healthcare providers with the Hippocratic Oath to take care of patients amidst rain, sleet, snow, or global crisis. The focus of today's event will be on safely restarting cardiac surgery and resource optimization. There will be three themes led by worldwide leaders that include: 1, best practices to reduce kidney injury, management of retained pericardial blood after surgery, and enhanced recovery after surgery. We want this event to be interactive and encourage you to submit questions via the question and answer button at the bottom of your screen. For submitted questions, we encourage you to upvote the ones that you like to help us triage the important questions. Before we start, I'd like to submit a poll to better understand the top challenges or areas of focus in restarting and planning for the future. You'll see a poll show up on your screen if you can take the next several seconds to vote on the poll. And I'll read the poll questions. What are your program's top 4 challenges or area of focus in restarting and planning for the future? Again, you can choose 4. Patient supply, reluctance to come to the hospital, adequate staffing, understaffed, staff safety, PPE supply, staff stress, burnout associated with COVID, patient safety, providing protection through perioperative experience, ICU resources, facility financial constraints, and uncertain future constraints. We'll give another 10-20 seconds. If you can please vote, and I'll share the results for the entire group. I'll go ahead and end the poll, and I'll share the results. So it looks like it was relatively evenly distributed, and probably the top 2 most important concerns were patient safety and ICU resources. All right. The first theme revolves around acute kidney injury. Dr. Alexander Zarbach, professor of anesthesia and critical care at the University Hospital in Munster, Germany, will talk about reducing cardiac surgery associated AKI. Dr. Zarbach.
Tom, thank you very much for the kind introduction. So I will talk about cardiac surgery associated AKI and how we can prevent this complication. AKI after cardiac surgery is a common complication and is associated with an increased morbidity as well as mortality. Here you see the pathophysiology of this syndrome, which is quite complex and is not fully understood. The hemodynamic situation as well as the volume status are 2 important factors in the pathophysiology of cardiac surgery associated AKI. In non-cardiac surgery, it has been shown that short episodes of hypotension may induce postoperative complications. This retrospective analysis, which investigated more than 30,000 patients, the authors demonstrated that mean arterial pressure less than 55 millimeters of mercury predicted adverse cardiac and renal-related outcomes. This was a retrospective study showing the association between hypotension as well as acute kidney injury. This is a prospective randomized controlled trial which was performed in France, and here the authors investigated the effect of the individualized blood pressure management of postoperative organ dysfunction. and they defined the primary outcome as serous and organ dysfunction within 7 days after surgery. In the standard group, the systolic blood pressure was kept above 80 millimeter of mercury, and in the individualized group, the systolic blood pressure was kept within 10% of the reference value, and the authors demonstrated that less patients in the individualized group met the primary outcome. However, no evidence in cardiac surgery patients exists showing that there is an association between hypotension and the development of acute kidney injury, but I think we should stick to the physiology, and there is a clear relationship between the GFR and the renal blood flow. GFR depends on an adequate renal perfusion pressure. The renal blood flow is autoregulated. Patients who have a chronic hypertension, here the curve is shifted to the right, and regulation of renal blood flow is important to maintain a stable GFR. Here you see the determinants of the mean arterial blood pressure. So the stroke volume, which influences the cardiac output, is dependent on the end systolic volume, which is influenced by afterload and contractility, as well as on the end diastolic volume, which is influenced by the relaxation and the preload. And that means on the volume status of the patients. You all know this curve. This is a Frank-Stahlen curve, which shows the relationship between stroke volume and the left ventricular end diastolic volume or pressure. And if you optimize the preload, you can increase the stroke volume until a certain point, and this is true for patients with a normal myocardial contractility, as well as for patients with a reduced myocardial contractility. So if you have an absolute hypovolemia, for example, in the context of bleeding, you have to give fluid. If you have a relative hypovolemia, you have to give vasopressors as well as fluids. However, we should avoid the extremes as shown in this figure. So we should avoid a hypovolemia because then the cardiac output goes down, as well as the perfusion of the organs. On the other side, we should avoid definitely a hypovolemia, especially in patients after cardiac surgery, because a lot of patients have a right ventricular dysfunction, and this increases venous congestion and reduces the perfusion of the organs. In the last couple of years, several trials have been performed investigating different measures to prevent and treat acute kidney injury, however, without any success. So there is currently no specific therapy available. In 2012, the KDIGO guidelines were published, and nowadays we use the KDIGO criteria to diagnose and stage an AKI. But here I want to focus on the fact that both functional parameters have several limitations. The urine output has a low specificity because it can be influenced by several factors, for example, the use of diuretics or hypovolemia, and the serum creatinine has a low sensitivity because the creatinine levels only increase if we lose more than 50% of the GFR. And especially in cardiac surgery patients, the serum creatinine has a low sensitivity due to the fact that there is a hemodilution during the use of the cardiopulmonary bypass. That's the reason why we should use stress and damage biomarkers. With these new biomarkers, we can detect the golden hour of acute kidney injury, and this means an increased risk and kidney damage, which are clinically silent. And the functional biomarkers can only detect a decreased GFR and kidney failure. We know a lot of biomarkers, and the best evaluated biomarker is probably still NGAL, and in this study the authors demonstrated that NGAL can predict the development of acute kidney injury after cardiac surgery. However, the authors also demonstrated that NGAL has also some limitations, especially in patients who have a chronic kidney disease. Here the predictive value was not as good as in patients with a normal kidney function. There are two new biomarkers which are involved in the G1 cell cycle arrest, that's TIM2 and IGF-BP7, and we investigated the predictive performance of these new biomarkers in patients undergoing cardiac surgery. And here you see that the predictive value of these two biomarkers is quite good, with an area under the curve of 0.896. For a composite value, that means the highest value within the first 24 hours. But if you only want to measure the biomarker once, you should measure the biomarkers 4 hours after cardiac surgery. And here, the area under the curve is still quite good. It's 0.805. In 2012, the KDIGO guidelines were published, and the guidelines recommend to implement a bundle of supportive measure in high-risk patients. And nowadays, we have the ability to identify the high-risk patient by using these new damage and stress biomarkers. And we wanted to know whether the implementation of the KDIGO bundle in high-risk patient can reduce the occurrence of AKI after cardiac surgery. And we looked at high-risk patient by using TIM2 and IGFBP7, and only patients with an elevated biomarker equal to or higher than 0.3 were included. If the patient were randomized either in the control group, here they received the standard of care, or in the intervention group, and here we implemented the KDIGO bundle. And here you see the hemodynamic algorithm we used. First of all, we looked for the volume status by using the stroke volume variation. In the next step, we looked for the cardiac output, and in the last step, we looked for the mean arterial pressure. And implementing the KDIGO bundle in high-risk patients significantly reduced the occurrence of AKI after cardiac surgery from 71% to 55%. But if you only look for moderate and severe AKI, this was also significantly reduced from 45% to 30%. When we published the study, everybody told me that in their institution, every patient is treated according to the KDIGO guidelines. And I couldn't believe this, and that's the reason why we performed a survey. And here we demonstrated that only 5.3% of the patients after cardiac surgery really received the full KDIGO bundle. And we also performed an interventional trial. This was a Prevaki 2 trial. Here, the primary endpoint was a compliance rate. That means the percentage of patients who are treated according to the KDIGO guidelines. This was a multi-center trial, and we recruited 280 patients in 12 centers in Europe, and we also looked for moderate and severe AKI. And here you can see on the left side that more patients in the intervention group received the full bundle, 63% compared to 5% in the control group. And this was associated with a significantly reduced rate of moderate and severe AKI. So in summary, we can say cardiac surgery-associated AKI is a common complication and is associated with an increased morbidity as well as mortality. A kidney damage without a loss of function is associated with an increased mortality. Different measures exist that might prevent the development of cardiac surgery-associated AKI, but only a small fraction of patients undergoing cardiac surgery receives the full KDIGO bundle. Thank you very much.
Thank you, Dr. Zarbach. So Dr. Zarbach talked about ways to reduce cardiac surgery-associated AKI. Our next speaker is Dr. John Kellum. He's the Director of Critical Care and Vice Chair of Research at the University of Pittsburgh. He's going to talk about the impact of AKI on long-term outcomes. Dr. Kellum.
You need to unmute, Dr. Kellum.
There we are. Sorry about that. Seems like the controls are a little temperamental when you're on a shared screen. So we'll try to get back to the beginning here. So thank you for that introduction. I'm going to talk about some of the epidemiology quickly as it relates to acute kidney injury and cardiac surgery. Years ago, and still today, if you look, for example, at STS criteria for acute kidney injury, you'll come to the conclusion that it's a relatively uncommon event. However, if we apply the KDIGO criteria for diagnosis of AKI, as Dr. Zarbach just showed you in his study, you actually find that the majority of patients meet some criteria for acute kidney injury. For example, in this study, looking at the Thrasos drug, we see that patients developed AKI at rates approaching 80%. Now, this was an enriched population with one or more risk factors, as shown there: low underlying GFR, advanced age, higher risk surgery type, near heart association, class 3 or 4 left ventricular ejection fraction less than 35%, history of diabetes or proteinuria or low hemoglobin. However, you just needed one of these, and I submit to you that the vast majority of the patients I take care of post-cardiac surgery, pre-cardiac surgery, meet at least one of these criteria. So it's actually very difficult for me to find patients that wouldn't qualify for this, for these risk factors. And of course, then also this event rate was based on any stage of AKI, including isolated and transient oliguria. Now, these are the criteria. These are the KDIGO criteria. I'm not going to emphasize these in great detail because I think majority of people are probably familiar with them. But you only need a 6-hour decrease in urine output or a small change in creatinine to meet these criteria. And it raises the question, I think, in many clinicians' minds as to whether particularly the transient oliguria is significant, and particularly in cardiac surgical patients. We spend a lot of effort to reduce circulating volume in these patients, to keep the field dry, to keep the lungs dry, and is transient oliguria really an pathology? Now, and outside the CTICU population, we have some evidence that isolated oliguria, as the same for isolated azotemia, and I'm not sure I can have a pointer here, but the columns here represent urine output criteria, and the rows represent creatinine criteria. And you can see that the boxes in blue represent either isolated rises in serum creatinine or isolated changes in urine output at a stage 1 or 2. And you can see that the mortality rate does increase, but it's certainly much lower than when there's a combination of both of these variables. So is isolated oliguria really an indicator of bad outcome in patients with cardiac surgery, undergoing cardiac surgery? These, by the way, are the mortality rates over time, or survival rates over time in those groups. The reason this is a concern, of course, is that as Alex mentioned, you really need to lose a lot of GFR before creatinine goes up. So does oliguria represent injury to the kidney in the absence of a change in creatinine, in the absence of a loss of GFR that's really as dramatic as would be shown here? Or does oliguria lead to fluid overload, and does that complicate other organ function and cause organ injury and cause morbidity? So for either of those reasons, oliguria may be more than just an inconvenience for clinicians. So we decided to look at this in our population. This is a study that looked at over 7,000 cardiac surgical patients. We then excluded the sort of usual things like transplants and patients receiving ECMO and LVADs, et cetera. And we ended up with over 6,000 patients, 6,600 patients undergoing cardiac surgery. This was done at 5 centers within our medical network, including rural community hospitals, inner city hospitals, and academic hospitals. And the results really are shown here, that again, about 80% of patients develop AKI, but half of that is isolated oliguria. The other half is a combination of isolated azotemia, rise in serum creatinine by itself, or about a third of patients have both creatinine elevation and urine output change. And the primary endpoint was major adverse kidney 80 days. This is death, dialysis, or persistent renal dysfunction. And you can see there's a small but statistically significant, and certainly from a relative risk increase, there's a large relative risk increase going from no AKI to just isolated oliguria. Interestingly, this was coming not from death or dialysis, but entirely from new onset CKD. So these are patients who have isolated oliguria, no change in serum creatinine acutely, but then when you follow them up at 180 days, you find that they have worsening renal function by serum creatinine and meet criteria for CKD. If their creatinine and urine output goes up, then the increased event rate in terms of MAKE is quite substantial, and it's coming from both new onset CKD as well as death. Dialysis rates are still pretty low. They're in the 1% to 5% range in this population. So it's mostly coming from death and CKD. Now, to just break this up a little bit more, these are the individual groupings with respect to outcomes. This is the isolated oliguria here in red, and you can see in terms of MAKE 30 days, MAKE 90 days, MAKE 180 days, there's about a third more, up to 50% more events occurring in this group. And then as you add in changes in serum creatinine at increased severity of oliguria, you begin to see higher and higher events. This is just another way of showing that. About a quarter of the patients, about 40% of the patients develop isolated oliguria. About a third, a little more than a third of patients have both oliguria and azotemia, or right in this particular bar, just azotemia. And you can see that the rate of MAKE at 180 days progressively increases with the severity of that. These are the stages of both urine output and serum creatinine. Interestingly, some of the things you would have predicted, for example, underlying CKD, stage 3s and stage 4s are dominantly occurring in the patients in the higher risk clusters. Those bars to the left of the previous slide, whereas isolated oliguria really doesn't show any increased risk in terms of underlying CKD. There's a slight increased risk in the type of surgery and in the Thacker score. These are the mortality curves, survival curves. As I indicated already, the patients in cluster 2 isolated oliguria don't die more often. Their endpoint MAKE is coming from increased CKD. So this new onset CKD, of course, is concerning. The actual numbers are here. 8.1% of patients in isolated oliguria compared to 5.2% of patients without AKI. If you use the denominator of patients without any evidence of CKD at baseline, you have 9.6% of patients developing new onset CKD compared to 6.1%. Why is this happening? It's likely that isolated oliguria is just an indicator of kidney damage that occurs in patients with enough renal reserve that their creatinine doesn't go up. And in at least some of these patients, this indication of kidney damage plays out in permanent damage that is estimated by their EGFR at 6 months. So in conclusion, cardiac surgery-associated AKI is common. It's associated with both short and long-term harm. Isolated oliguria portends a worse prognosis, even in cardiac surgery patients, with a 50% increase in the rate of new onset CKD. The STS and the EU criteria for acute renal failure do not identify most patients with acute kidney injury undergoing cardiac surgery, and changes to a sort of all KDIGO stages for AKI and also encouraging long-term follow-up in these patients is something we have to seriously consider. And with that, I thank you for your attention.
Thank you, Dr. Kellum. I want to encourage the attendees to submit questions. If you have any questions, please submit via the question and answer button. We'll have a discussion at the end of every presentation, at the end of all the presentations. We're going to change gears a little bit and talk about retained pericardial blood. Our next speaker is Dr. Spencer Melby. He's a program director and associate professor of surgery at Washington University Barnes-Jewish Hospital in St. Louis. And he's going to talk about the toxicity of inadequate pericardial drainage, implications for patient recovery. Dr. Melby.
Thanks, Tom. Happy that I could be here and give a little presentation from St. Louis. I hail from Barnes-Jewish Hospital and Washington University in St. Louis, where we've done research on AFib for many, many years. And I've focused my research on postoperative atrial fibrillation. As a complication goes, it's the most common complication after heart surgery. And despite decades of basic science and clinical research, we haven't really made a dent in it. It just continues to persist. It's associated with mortality, strokes, increased length of stay, and it's expensive. It's over $10,000 per patient when it occurs. And this is just a graph that shows here at Barnes-Jewish Hospital, we looked back into the 80s of people that had heart surgery and what their rates of post-op AFib. The solid line there shows that all patients, all cardiac surgery have a rate around 30%. The dashed line is just isolated CABG patients. But you see that despite all this research and efforts to reduce post-op AFib, over the course of several decades, we still have a rate of around 30% of post-op AFib. And that's what we have today even. And my research has been focused on the pericardial space and what is it in the pericardial space that might give you a risk for post-op AFib. There are many preoperative risk factors that we know, primarily number one being age, but here's a list of things that increase your risk of post-op AFib after surgery or complications if you had an MI or heart failure or respiratory failure. But the last one on the list there is hemorrhage, and that's what I want to focus on for just a moment here. If you have bleeding after heart surgery, your risk of post-op AFib goes up. In that same study we did over the last 30 years at WashU, if you had an operative re-exploration for bleeding, your risk for post-op AFib increased by 40%. And I think that there's a good reason why that may be. And the blood and blood breakdown products, they really are highly oxidative and inflammatory. There's another study that came out of UK that showed essentially the same thing. This 10-year retrospective study showed in 17,000 patients that had heart surgery, if you had a re-exploration for bleeding, so you're bleeding enough that you had to go back to the OR, or if you had a 10% increase in your ICU output of your cardiac drains, those patients had a 40% increase in their post-op AFib. So those findings pushed me to look in the pericardial space and say, if you have a lot of blood in the pericardial space, what might be a contributor to post-operative atrial fibrillation? What we did over the course of the last several years, I started in Alabama studying this and collecting about 30 patients in Alabama, but since we've collected pericardial fluid on 100 patients here in St. Louis, and right at the time of surgery, we collect pericardial fluid, and then at hour 4, 12, 24, and 48, we collect fluid right out of the pericardial drains. And then we've done a bunch of analysis on these, including cytokine levels of neutrophils by flow cytometry, and I'll show you some PCR of mitochondrial DNA that we found. This is just a single representative slide of the contents of the pericardial, the cellular contents of the pericardial fluid as analyzed by flow cytometry. If you're familiar with flow cytometry, you'll know that the cells pass through and are gated, and certain cell populations will cluster in this little box. On the left there says intra-op. You see in the square that's drawn there, that square would represent neutrophils in the pericardial space. And you see intraoperative or before surgery, there's essentially no neutrophils in the pericardial space. And the cell population represented in the lower left of that graph would be monocytes, which is what we know reside in the pericardial space just in a quiescent state. But within 4 hours, so after surgery, they come into the ICU, 4 hours later, we collect the pericardial fluid. You see now in that box that there is a large neutrophil population, and that persists at 12, 24, and at 48 hours. So within just a couple of hours, we have what one of my immunology friends called a neutrophil riot. This is a huge increase in the number of neutrophils in the pericardial space. And we did flow cytometry in about a dozen patients, and this is the percentage of neutrophils at 0 hours, 4, 24, and 48 hours after surgery. You see at 0, there are essentially no neutrophils in the pericardial space, but within 4 hours, you jump up to a mean of around 40% of these cells are neutrophils. And within 24 to 48 hours, you have over 50% of all those patients have, over 50% of the cells in the pericardium are neutrophils. We assess to see is that an indicator of who gets post-op AFib if you have higher neutrophils? And it looks like it is. The p-value in these dozen patients came out to be 0.06, but 63% neutrophils in the pericardial space was higher than the 40% if you didn't have post-op AFib. So we think that the neutrophil count and then what the neutrophils are doing in the pericardial space increases inflammation, oxidation, and all the stressors that can cause post-op AFib. This is just a little panel of some of the cytokines we looked at in about 100 patients. We collected the pericardial fluid at several time points. You see those time points I listed before. The blood is represented by the black and green lines of whether they had post-op AFib or no post-op AFib. That black and green line is what the cytokine level is in the blood. The red and blue line is what the cytokine levels were in the pericardial space. These scales are logarithmic scales. So you can see that in general, these inflammatory cytokines, TNF alpha, interleukin 8, 6, 1B, 10, you see that these are 10 to 100, some of them 1,000 times higher level of these inflammatory interleukins in the pericardial space than what's found in the blood. C-reactive protein, which is made in the liver, is the opposite. But most of the inflammatory cytokines are extremely high in the pericardial space, much, much higher than what's in the blood. And we also, besides just looking at the neutrophil count and the cytokines, we looked at mitochondrial DNA. Mitochondrial DNA recently has been implicated as a damage-associated molecular pattern, something that causes in and of itself inflammation and recruits neutrophils and other cells of inflammation. And we looked at these 100 patients that had the pericardial fluid. We found that within 4 hours, the mitochondrial DNA levels are higher in patients who have post-op AFib in the pericardial space. And that was highly statistically significant. That, again, this is a logarithmic scale, so it sort of underplays the difference, but there's much higher levels of post-op AFib in patients that have this high level of mitochondrial DNA in their pericardial fluid. When we did a multivariable analysis on who got post-op AFib, age, which generally comes out in every study came out, but the other factor that came out positive for a risk factor for post-op AFib was the mitochondrial DNA level in the pericardial fluid at 24 hours. So something in that fluid is contributing to post-op AFib. And this slide just marks, again, it emphasizes the point that it's not in the peripheral blood. The green and orange line on the bottom are the levels of mitochondrial DNA in the peripheral blood. That didn't correlate with post-op AFib, but something in the pericardial fluid, mitochondrial DNA, did correlate with post-op AFib. And this just emphasizes the point a little bit that all these studies that have been done, we've done dozens and dozens of studies on post-op AFib looking at serum markers. Well, if you're looking in the serum, it's kind of like listening to trying to figure out who's winning the ball game by listening to the crowd outside of the stadium. You got to get in the stadium to see what the score is. Same thing here. If you're in the pericardial space, you can find some things that are going to contribute to post-op AFib. So those studies, we showed that neutrophils are certainly on the increase. There's a neutrophil riot in the pericardial fluid, and that's associated with an increase in cytokines. Mitochondrial DNA is 150 times higher in the pericardial space than what's in the peripheral fluid. And that local release of mitochondrial DNA in the pericardial space is associated with post-op AFib. This might be a mechanism that contributes to post-op AFib and a possible new therapeutic target. So where do we go with this? Well, just to finish my little summary of our study, if you look at what's in the pericardial fluid, and there are bad things in the pericardial fluid, a neutrophil riot, mitochondrial DNA, oxidative stress, you wanted that to get out of the pericardium. Anyone that's taken care of cardiac surgery patients and pulled chest tubes has seen just what this picture shows. They've seen clogged chest tubes. Chest tubes often don't do adequate job of draining the pericardial space. For years, we've put in pericardial drains in the fear of tamponade. We can't let a patient tamponade, and of course, that's important. But I think that chest tubes serve a second purpose that's often overlooked, and that is they help reduce the accumulation of products in the pericardial space, such as the ones that I just described, that may contribute to post-op AFib. And that may indeed be why a study like this, Dr. Fischlein did a really nice study in Germany a few years ago, where they use these chest tubes that have the active clearance technology, and by clearing out the chest tube, they maintained chest tube patency. And in phase 0, you see that the post-op AFib rate was around 30%, like what we see in today's world of post-op AFib and cardiac surgery. In phase 0, they just had their routine chest tubes, the ones I just showed a picture that looked like they clogged. In phase 1, they figured out how to use the chest tubes. And in phase 2, they studied again and say, what's our post-op AFib rate? And they had a significant reduction in post-op AFib, about a 30% reduction in post-op AFib, just by simply making sure that they had patent chest tubes by using that active clearance technology. And then they went to a further phase and they went back to the old chest tubes and say, well, is this just because we're taking care of our patients better? But indeed, when you use the old chest tubes that clog, their post-op AFib rate went right back up. So this is just a little further clinical evidence that if you can keep the pericardial space adequately drained, you can keep some of those harmful factors out, you may be able to reduce some complications here. We've had some studies that have shown that here at Barnes Hospital, that we're putting together some papers that show just that. In summary, post-op AFib, it's common. It's the most common complication. It has morbidity. It has mortality associated with it. There's a lot of contributing factors. There's not just one problem, but one of the things that may be contributing is this inflammation and oxidative stress, including mitochondrial DNA in that pericardial space. And if you can get those things out of the pericardial space, if you can drain them better and you get those those bleeding breakdown products out of the pericardial space, you may indeed decrease your postoperative atrial fibrillation rates. So that was a lot to jam into 8 minutes, but there you have it, 8 years of research in 8 minutes. Thanks for listening and thanks for tuning in.
Thank you. Dr. Melby. I have to admit, I like that term neutrophil riot, and I guess we have to do what we can to minimize the rioting of the neutrophils in that pericardial space, whether it be drainage or other modalities. Speaking of which, our next speaker is Dr. Luis Peralt. He's the head of the Department of Surgery at the Montreal Heart Institute, and he's going to talk about innovations in pericardial drain management that might be able to minimize this neutrophil riot.
Thank you very much, Tom. Thanks to the organizers, ladies and gentlemen. It's a pleasure to carry on with a little bit of clinical data on some of the concepts that Dr. Melby has been expanding on. So, you know, blood outside blood vessels is never a good thing. So, you know, shed mediastinal blood, it can lead, we know this, tamponade, pericardial effusions, hemothoraces, pleural effusions, and the blood in the mediastinum, as we've seen, contributes to a highly pro-oxidant and pro-inflammatory milieu that can trigger, among other things, postoperative atrial fibrillation. Now, in 2019, as published in JAMA Surgery, the guidelines for perioperative care were enunciated, and 2 of them concerned chest tubes. The first one, which was a strong recommendation, was a 1 BNR, was that maintenance of chest tube patency is recommended to prevent retained blood and retained blood complications. And the other one concerns stripping or breaking the sterile field of chest tubes to remove clot. This is maybe dangerous, not recommended. Now I'm going to share with you some clinical results regarding one way to achieve maintenance of chest tube patency that's worked well for us at the Montreal Heart and also others. And I thought I'd just show you what it looks like at the bedside. Basically, there's a catheter with a clearance wire with a loop inside that is inserted between the chest tube and the drainage tube. I'll show you the video. So basically the wire inside the catheter is magnetically attached to a guide in the outside, and the wire is actuated and by moving the guide. And this enables the wire in the loop to keep the chest tube patent and when it's regularly actuated. So this is done on a regular basis in the first few hours after surgery, and then progressively less until chest tube removal. Let me show you a prospective randomized trial that we carried out and presented at the late-breaking clinical trial at the AATS last year. So we randomized 520 patients. 249 had a active clearance technology. The other half basically had standard mediastinal chest tubes. And the primary endpoint was effect of active clearance on outcomes, and the secondary endpoint was looking at the patency of the chest tubes upon removal the day after. And you can see that there was a 42% reduction in reintervention for retained blood. We're talking about a pleural effusion drainage, additional chest tubes. You could see that there was a 70% reduction in re-exploration for bleeding. So our take-back rate went down from 5% to 1.7. There was a 15% reduction in post-op AFib. And obviously, because of this technology, the chest tube occlusion rate went down 90%. I mean, most of the active clearance technology tubes were patented the next day. This is another study from a private cardiac surgery setting in the US from Barabo and collaborators. It's a propensity match analysis. You can see that almost 700 patients. The phase 0 is the same as described before by Dr. Melby. Basically, the old way of doing things with standard chest tubes. There was a training and compliance phase, and then the active clearance phase looking at primary endpoints of incidence of retained blood complications, but also interestingly looking at associated hospital resource utilization after cardiac surgery. Now you can see across the board that there is, with active clearance technology, there was in this study a reduction in ICU length of stay, a greater length of stay than 3 days, and total post-op length of stay. There was also a decrease in ventilator time, and all of this the consequence of all of this, or the benefit, was a mean cost reduction of close to $2,700 US, and this includes the cost of the catheters at 1.2 active clearance systems per patients. If you look at peer-reviewed outcomes data, and then you can see these are studies on both sides of the Atlantic, both in the US and Canada. You can see that if you look at retained blood complications, there are significant reductions at the level of 40, 60% in the left panel. You can see that there are consistent reductions in length of stay. There's a reduction in postoperative atrial fibrillation, depending on the population, 15 to 33%. And there's a great reduction in re-exploration rates from 60 to 70%. And in different patient population. One of the studies was in VAD patients, the Malte study. So in conclusion, the use of active clearance technology is associated with a reduction in retained blood complication, post-op atrial fibrillation also, and there is a decrease in ICU and hospital resource utilization and median costs. So we believe that efforts should be actively maintained to preserve chest tube patency in the ICU and after surgery, and this would improve outcomes and is definitely economically justified to help reduce hospital resource utilization, especially in this COVID or post-COVID-19 era. Thank you for your attention.
Thank you, Dr. Peralt. Just again, as a reminder, please keep the questions coming. We see a live stream of the questions, and we do our best to answer as many as we can at the end of the next presentation. Now we change gears a little bit, and now we'd like to talk about enhanced recovery after surgery. This talk will be given by Dr. Alexander Gregory. He's an assistant professor at the Cummings School of Medicine and Living Cardiovascular Institute at the University of Calgary. He's going to talk about why it's important to optimize recovery after cardiac surgery now more than ever. Dr. Gregory.
Thanks for inviting me this morning. We'll cover, as Dr. you said, we're going to talk a little bit about what kind of enhanced recovery options there might be within this new reality of coronavirus pandemic. So at the end of the day, most of us joining in this conversation are either currently in one of these phases, have been, or will be in one of these phases. And each one has its own unique challenges and dynamics to it, but there are a couple challenges that they have in common that I'd like to talk about this morning. So the first of one of those challenges is the backlog that has been created by the necessity to delay elective and in some cases even semi-elective open heart surgeries or other cardiac procedures, both to maintain patient safety in terms of not having them need to come to the hospital, but also because of the redistribution of resources that has been required to manage this pandemic. So now many of us are either trying to minimize how big this backlog gets, or if we're emerging from our surge phase, we may be starting to look at how do we tackle it, bringing this backlog down. Now, there's been an interesting paper that was just recently published by some colleagues, and they looked at some data from several institutions, and basically compared their pre-COVID numbers in terms of elective surgeries and patient flow through, and then modeled how much you would have to increase from your baseline abilities to catch up, for lack of a better word. And so, you know, when you look at here, even if you can go to 150%, that will still take most people 3 months potentially, and 120% could take up to 8 months. And that's assuming you start on July 1 and you're hitting 120% starting right away on July 1. Now, I know most healthcare systems in the world, they're not all equal, but one thing they do have in common is most run at pretty much full capacity at all times. I don't think a lot of people have a lot of spare capacity just laying around. So this can be quite challenging. A second challenge, and it's unique to cardiac surgery, is just the degree of competition that we have for resources with coronavirus. So, you know, we have direct competition for manpower, both MD and non-MD. We have competition for beds, ICU and ward beds, and then a lot of crossover in terms of resuscitative and critical care equipment and medications. So, you know, we're not only going to be needing to increase capacity, but we're going to be doing this in an environment where we're directly competing for important resources. So how do we really accomplish this? I mean, obviously, working harder is always an option. We can work smarter. Probably one of the reality is it's going to be a combination of both. And all of us are really trying to avoid that dreaded requirement of having to send our patients elsewhere. So how does enhanced recovery fit into this plan? So we've recently published a set of recommendations that outlines 22 interventions that could be considered as part of an enhanced recovery program. Now, this is, I think, a good starting point. I don't think that this is necessarily an exhaustive list of interventions. What's more important is that the concept of ERAS, which is one of being able to build a team, collaborating internally and externally, having the ability to do dispassionate and data-driven self-evaluation, and then using this information to develop a program that aims to improve patient outcomes, the patient experience, but also use healthcare resources more effectively and efficiently. So we don't have, in the enhanced recovery world, we don't have the same amount of data that some of the non-cardiac surgery specialties have, because we started a little bit later. But the data we do have is quite reassuring and promising, and I think it lends itself to looking forward that this could help within the coronavirus era. So the very first published paper using an enhanced recovery program showed a decrease in complications. I apologize, I didn't put any p-values, but all of the reductions I'm going to show are all statistically significant. And then there was a randomized control trial out of China that showed a decrease in length of stay, cost, as well as total complications. Then Dr. Williams published the results from the first US-based program that again showed a decrease in both length of stay of hospital and the intensive care unit. And then Dr. Grant and the group at Johns Hopkins showed that they were able to reduce hospital length of stay and intubation time implementing an enhanced recovery program. So I think you can see here that the results tend to show that we can help work smarter, not just harder, if we can try to find a way of leveraging the concepts of enhanced recovery in our current environment. Now that seems easy to say, and I think that a lot of people will have the common thought of, how can I possibly start a program now? Everybody is burned out. Everybody's been pushed to the max. There's been protocols and Zoom meetings every day on dealing with coronavirus. So this is not a good environment to try to initiate some new change. Now that may be partially true, and I don't disagree that the coronavirus has presented some challenges. But if you look at a very simple model, I know there's a lot of models out there for organizational change, but I always like this Gleitcher formula because it's very easy. It works as a nice litmus test for where you are currently in your organization. So if you look at it, it basically talks about that if the letter C is change, it's a combination of the dissatisfaction within your group of the status quo, the desired clear state, or which is the vision, and then the practical steps, or in other words, the plan. And the combination of these have to be greater than the perceived cost of change for that to actually work. And so I think that the COVID pandemic has actually provided an opportunity in some respects. And I want to focus in on a couple of them. So the first one is this idea of dissatisfaction with the status quo. The reality is, one, I think, of the barriers of enhanced recovery is that most hospitals are doing a pretty good job already. I mean, we're not out there doing bad surgery and providing bad care for our patients. And so I think that is great, but it can actually become a barrier in and of itself because the status quo can be quite powerful for that reason. But now the status quo has changed. And I think that being good may no longer be good enough if you're trying to catch up on a backlog or provide the safe care for your patients in this current time. So I think that this is an area that is now can be used as an opportunity to promote change in your environment or at your institution. Secondly, if you look at the cost of change, I actually like dividing it into not just the cost of change, but the perceived cost of not changing. And I think that really now has become much more obvious to anyone dealing in the healthcare system that we're going to have to change, and the cost of not changing is going to be dramatic. And so I think that one could look at this and say, you know, I think building a very comprehensive, large program could be challenging and may not be feasible for a lot of people. But I think that the idea behind building a small, focused group and bringing in a concise, focused, enhanced recovery program is feasible in coronavirus for lots of reasons, including some of the ones I've just mentioned in terms of the environment for change being a little bit more conducive. But the nice additional benefit would be if you're able to bring in an enhanced recovery program now, even if it's small, you'll be laying critical groundwork and creating the network of people, the network of resources, socializing the concept of enhanced recovery at your institution. And then this platform can then be used to grow your program into a more comprehensive one when the environment is a little bit more conducive to that. So in conclusion, I feel that up until now, a lot of people, I believe, see enhanced recovery as a luxury, something that they do once everything else has been taken care of. And I think that now, in the face of COVID and all of the changes that we're going to have to make to successfully provide safe and timely care to our patients, that it is no longer a luxury, but I would argue, in fact, it's a necessity. Thank you.
Thank you, Dr. Gregory. This segues into the second poll question that I would like to launch. And this question is, what elements of the ARIS cardiac postoperative strategies have been implemented in your program? And as you can see here, there are a list of ARIS elements. If you can answer that, I also want to be respectful to the attendees and the panelists' time. I want to make sure we have a hard stop at the hour. While you answer this poll question, I want to present a question to our panelists. This came up by two attendees, Dr. John Puskas, as well as another attendee asked, what is the advantage of doing a posterior pericardiotomy to drain fluid from the mediastinal space into the pleural space to minimize that neutrophil riot and storm that Dr. Melby talked about? I'd like Dr. Melby and Dr. Peralt to give their comments on this question.
Louis, you want to go ahead? I typed an answer to Dr. Puskas. He may disagree with me, but what are your thoughts?
Yeah, I was looking for your answer. John is totally right. There is literature that has shown that a posterior pericardiotomy decreases post-op AFib. But if you question, if you question big time, at least in North American surgeons, it does not seem to be a very common practice unless, you know, the people that are advocates are not really promoting it too much. There seems to be an increase in pleural effusion, so you may have to modify your pleural drainage strategy, keep the drains longer, et cetera, and it has been associated with increased complications. So if it's well done, it could serve the same purpose. You may have a shift of complications through the pleural space, but there is definitely evidence. I think that one of the things that would be amazing would be to compare it, that strategy versus active clearance, and to see whether the outcomes would be the same.
I totally agree with you. I think that it, in theory, would be a great way to go, but very few surgeons are willing to do it. The last few studies that I saw that looked at trying to pile a bunch of data together weren't as promising as some of the earlier studies. Some of those early studies looked great, like, oh boy, this is a great way to reduce post-op AFib. So there's kind of two impediments. One is it may not work as great as we thought. And maybe the bigger one is how do you get surgeons to make a slit in the posterior pericardium? Not a lot of surgeons want to go back there and actually carry that out.
That's maybe that's an opportunity for a study, as Dr. Pearl alluded to compare those two modalities and see if there's a potential reduction in AFib. On that line, what's the data for the number of chest tubes placed to adequately drain? Again, I love that neutrophil riot, so I'm to minimize that neutrophil riot, Dr. Melby. And what about the type of chest tube you place? You know, whether it be a Blake and Argyle, and the location of the chest tube. Has that been looked at to maybe minimize some of the rioting that takes place?
Well, Dr. Pearl just gave some really nice evidence about the placement of the active clearance chest tube. So I think that you do gain some advantage by using a tube that is patent. The Blake, we had several questions. I typed some answers that people asked, what about the Blake drain? What about the Blake drain? And maybe 10 or 12, 15 years ago, the Blake drain became a really popular choice. But what was found in the adult population was that they tended to clog off just as often and sometimes more frequently. We had at our hospital some tamponade. We had to emergently go back and re-explore for tamponade, and we had used the Blake drain. So the pediatric docs seem to like them better because they're a little smaller, a little softer, but I don't think that they're really much better in the adult population at draining the pericardium. And then you ask the question, how many chest tubes? Well, probably more is better, but how many is adequate is the real question. And I think if you have one tube that's patent, you're going to do a pretty good job of draining because a whole blood will come out that hole. And if you have a good patent chest tube, then that should be adequate. But we usually put in 2 and sometimes 3 chest tubes. And it's because we're fighting this problem of the chest tubes, they clog off. What do you think, Louis?
Yeah, I think you're right that one of the things that's very hard is to know the effect of systematically putting a posterior chest tube. Does that change something? Well, I just want to, in a minute, we did the Blake study. We did this in the combined procedure patients, aortic surgery patients. We were looking to decrease pericardial effusions 1 month post-op, and there was no effect. Interesting, in that group of patients, the baseline post-op AFib was 50% because they had multiple valves, combined procedures, not 30%. And there was no effect on the Blakes and no effects on pericardial effusion 30 days out. We still use them, but definitely not a panacea, and they clog quite often too.
Again, I want to be respectful of the time. One question that came for Dr. Zarbach from Giselle Catalan, aside from mean arterial pressure and volume, what other intraoperative perfusion, bypass strategies, interventions would you recommend to prevent AKI? If you can answer that within a minute, and then we'll move forward with a poll and start wrapping up. Thank you, Dr. Zarbach. And if you can unmute your thank you.
Thank you for the comment. So there is actually no evidence to use an increased blood pressure during cardiopulmonary bypass. There is only one randomized controlled trial which investigated this, and they demonstrated that there is no difference between both groups. What you can make to avoid AKI after cardiac surgery is so that you don't use hydroxyethyl starch, for example, or that you don't use saline. And then I think you have to keep the mean arterial pressure above a certain threshold, whether this is 65 millimeter of mercury or 70 millimeter of mercury. That probably depends on the comorbidities of the patient. But other than this, you don't have anything you can do at the moment.
Thank you, Dr. Zarbach. As you can see, I share the poll results with elements of ARIS, and I'm going to have Dr. Gregory comment on the poll results and say a comment on whether or not the focus is right, or if there are missed opportunities out there, and then I'll start to close. Dr. Gregory, I'll give you the second to last word.
Perfect, thank you. No, I was looking through, so I think it makes sense. I think people have looked for, as most do, look at the low-hanging fruit first, which is the right way to go. You don't want to try to overstretch too early on. I think that I think one of the areas if you look at, I mean, I'm an anesthesiologist, so maybe I'm biased towards the post-op pain management, but I think that you can get a lot more bang out of your buck from a combination of multimodal analgesia, not only for better pain management, but the opioid sparing component of it could definitely reduce complications and help move patients through more comfortably, but still more quickly. So that makes sense. And then I think the extubation strategies is a big one. I think to me, you look at easy, low-hanging fruit in this era is stuff where you're changing human factors, behaviors, status quo, habits. Those are things that aren't data-driven. And a lot of extubation strategies, why do we do what we do, has nothing to do with patient safety or data. It's all about what we're used to doing. So I think that that's another one I would focus on.
Thank you. So as we wrap up, I wanted to thank our speakers who are from around the world and many of the attendees who are from around the world as well. It's our hope that during these difficult and unusual times, we're reminded that patient care always comes first. Today, we discussed best practices to reduce kidney injury, novel approaches to address retained pericardial blood, and why enhanced recovery is important now more than ever. And hopefully there are elements that you can take back home to your practice. Again, thank you for joining the event, and please stay well. Thank you.